guys. Hope the audio and the visual part is fine, so we can get started for the today's discussion, which happens to be a FMG recall session. And this helps you get an insight into the examiner's mind as well. So it's just not just a memory exercise. I mean, the objective of doing a recall is to see how we performed. And I know that you all have aced the paper excellently. So let's get started with the first question. And do let me know regarding the options, whether they match with the actual paper, though we have tried to be as accurate as possible. So what you have in front of you is a highly curated recall where we have tried to sit with students already and then try to come out with the most accurate recall that is possible. But yeah, I mean, I would like you to give inputs as well regarding in case you find that there are any changes with respect to the options. So I think this was a super easy one for everybody. Alcoholic patient with palpitation, syncopal attacks, and that very classical irregular pulse. And you know that we're dealing with a case of atrial fibrillation. And the moment we say that atrial fibrillation, we know that the A wave would be absent because the heart would be twitching. So, okay, raised JVP finding. Fine, I'll just add that as well. Okay, fine. That's great because it indicates that the patient would be going into congestive heart failure. But yeah, we still can come to the final conclusion because in any atrial fibrillation, the twitching part will ensure that the A would be absent. So great. I think this was an easy pickup. Let's look at the second one. Let me know whether this image was there or not. I mean, I'll just move myself a little away from the image. Yes. And you can check out a nerve that is very significantly thickened. This is, I'll say the name of the nerve. In fact, I'll let you say the name of the nerve here. But let me know if this kind of an image was present with respect to a nerve thickening. And yep. So what we are having in this case is a greater auricular nerve that would be thickened. And yeah, it's a type 1 DEPRA reaction. I mean, pretty straightforward and an easy question that you have to figure out in this particular case. Posterior cervical nerve. Okay, fine. So instead of posterior auricular, what you're saying is that there would be a posterior cervical as a word there. But anyway, if you look at the anatomical location of the nerve related to the sternocleidomastoid, this would be a greater auricular nerve, and therefore this would be answered by you as option number B. So great, man. I mean, you guys did an excellent job by picking up. I mean, this leprosy is something which is discussed in other subjects also. So I'm not sure if somebody else has discussed it, but I thought I should put up this question so that we can actually discuss the image as well, and we can talk about the neuritic type of leprosy or borderline tubercular type of leprosy that can have this kind of a presentation. Great. So you have to score. I'll be doing 50 odd questions with you. What you need to do is let me know how much did you score finally. Okay, so we have a patient of rheumatic heart disease. Loud S1 was given, right? And a mid-diastolic murmur. So again, a very characteristic one. I mean, the word loud S1 and mid-diastolic murmur helps you identify the valvular lesion. And that's going to be mitral stenosis. Please let me know in the comments if there is any variation with respect to the heart sound or the murmur. Like, the variation can be that it can be a soft S1 with a systolic murmur. So in case you find that there was like a soft S1, do let me know. Otherwise, yep, I think most guys are getting it correct straight away. Answer would be mitral stenosis. There is a narrowed opening, so the valves will have to be forced open, and when they're forced open, then they recoil with more force also, so that results in a loud S1 and very simple straightforward mid-diastolic murmur. So at the moment, smooth going. I think 3 out of 3 scores for everybody. Okay, loud opening snap, or even the word opening snap is again a clinching point. I mean, no other question talks about opening snap except for mitral stenosis. Last time they talked about severity. This time they asked about the diagnostic part. Okay, fine. Okay, 19 years of age. Fine. The age is not 25, it's 19 years of age. Great. Okay, when you're changing the patient to the left side, okay, left lateral decubitus. Great. That's an interesting input as well, because the heart will come closer to the chest wall, no? So that will make doesn't matter. Age will not determine anything. The more important thing is the loud S1 opening snap and a left lateral decubitus position. So I think let's not forget deliberate on the age of presentation. Let's focus on how the patient was presenting. Fine, we are sorted for this one. Let's move at the next one. We have this woman with headache and nuchal rigidity, and then the finding of star of death was there. And the moment I say that there is star of death, there is blood accumulating in the basal cisterns, we know that the diagnosis in this case would be subrecurrent hemorrhage. So piece of cake for everybody, guys. I mean, they are asking common things that we usually study: loud S1 with diastolic murmur, subrecurrent hemorrhage. Great. I mean, this was Aseptic meningitis. Okay, fine. Instead of pyogenic, it was aseptic meningitis. I'll be asking about a query meningitis question that came subsequently, but yep, easy peasy one. Okay. This is an interesting one. So one, I would like to not jump on answers. Please don't comment here. Meningitis feature with headache and vomiting. Okay. Okay, cerebral venous thrombosis. Fine. That would be venous stroke. For the next question, my request to you is please do not jump on the answer. My request to you is just please comment on which leads were showing the findings. Like I'll just zoom it into this ECG. We can pick up a ST segment, which is, okay, this is a much more thicker pen, so I'll use a finer pen, right? The ST elevation with the convexity features a meningitis. For previous question, are you sure? I mean, if there's a CT scan given with blood in the Sylvian fissure, then it would not go in features of meningitis. But okay, so lead number 1 is showing a ST elevation with a convexity. Okay, please comment regarding the leads, guys. I mean, I can pick up that leads, you know, V1, V2, V3, V4, very prominent in V2, V3, V4, a bit in V5 as well. Okay. Yeah, even in this one, I mean, there is a bit of T wave inversion that is coming up, but lead 1 is showing it. So guys, if it is gonna be like V1 to V4 and then we are moving on to a bit of finding in V5 and V6 as well, we'll think in terms of possibility of a anterolateral myocardial infarction. But my only concern is what I want to know from you is that was that a ST elevation with a convexity, or was it a ST elevation with the okay, there was a ST elevation in all leads and reciprocal in 1 and 2. Okay. TVL has a ST elevation. Yes, doctor. So it goes in favor of an anterior wall myocardial infarction only. So that would be the best bet. We have, my only concern is that are we having a ECG in which we are having a presence of ST elevation which is concave in upward direction? Because if we're talking about a concavity, then it would be going in favor of acute pericarditis. Okay. Okay, inferolateral is very much there. Fine. So I am sure about, like, you know, the findings that you have said, and now I'll focus on the theory part also. The question did mention regarding past medical history of a heart disease. Quick answers with respect to a yes or a no. If there was any past history of medical disease in a patient, there is history of vomiting, there is a chest pain in the guy, and there's a history of medical history of heart disease. Okay. Don't comment regarding okay, vomiting, epigastric pain. Epigastric pain. Okay. Since doctor, there is mention of reciprocal changes. A lot of guys are commenting regarding reciprocal changes which are present. So reciprocal changes is a feature that would always be present. Okay, vomiting, epigastric pain present in the guy, and on ECG we found these changes. Got it. But since you have mentioned the word reciprocal changes, we don't get reciprocal changes in acute pericarditis. I mean, if I'm saying is, if I say the word reciprocal changes, then it goes in favor of myocardial infarction only. So based on the inputs that you have provided, I'll go by option number A, that is a anterior wall MI or anterolateral myocardial infarction. Pericarditis, the point against would be that one, pericarditis presents with that very classical presentation of chest pain that is going to be relieved on sitting up. There is findings of pericardial friction rub. There's a ST elevation which is concave upwards, and then all the leads would be having a ST elevation present. Even lead number 1, 2 would be having a ST elevation. In contrast, in this particular ECG, it is lead number 1 only. So yeah, GRD features are given along with this. Okay, so features of pericarditis are like not given, but yeah, since you mentioned the word reciprocal changes, so therefore reciprocal changes are a characteristic thing that is seen only with myocardial infarction and nothing else. So we'll go by option number A for this particular question. The answer would be A. The next one talks about a broad QRS tachycardia. I'm not sure about if any blood pressure value was given, but do give me inputs whether any defibrillation was in the options. Yeah. Okay, BP was 90/70. Fine. Instead of 120/85. Okay. No, that's okay, doctor. I understand. I mean, the emetron is an answer. My only concern is any defibrillation was given in the question. Okay, so there's no defibrillation that is given. It's a ventricular tachycardia. I mean, it's a monomorphic VT. And in a case of monomorphic VT, as long as he's asking us to select between drugs, then the treatment would be given as amiodarone only. Great. Yeah, perfectly fine. If there's no option for defibrillation, nothing to worry. I mean, there's simple standard question for any patient having a sustained monomorphic ventricular tachycardia, which is lasting more than 30 seconds. We have to use amiodarone for the patient. So great. You guys are scoring very well. Moving to the next one, we have this woman. She's having a weight gain. I'm sure this must have been a woman, right? So do let me know regarding any gender-wise data that was given. Weight gain, thinning of hair, drying of skin. ECM self-mentioned Hashimoto's thyroiditis. I mean, this is like a piece of cake for you again. Anti-TPO antibody is the villain for Hashimoto's thyroiditis. Okay, so this was a female patient. Okay. Autoimmune disorders are common in women. So, I mean, that helps us. Okay, no gender was given. Fine. Still, the answer remains the same. Okay, moving to the next one. We have a road traffic accident patient. He received 4 units of packed RBC within few hours, and which of the following would be seen in this patient? Okay. Yeah, the commonest, most common antibody in Hashimoto's thyroiditis. Yeah, which antibody is seen? Which is the common antibody which is seen? Okay, I'll just add the word common there. That doesn't change the output though. Okay. Great. We have this patient who's having 4 units of packed RBCs given in a short duration of time. And if you are having a very fast transfusion being given, there is bound to be a development of citrate toxicity. No, guys, there's going to be citrate excess, no, because we have a additive solution which is present, and due to that additive solution citrate excess, what will happen is that the citrate will contribute to metabolic alkalosis, and this metabolic alkalosis can then cause redistribution of calcium, so it will result in development of tetany in a patient. Or another way you can remember is citrate simply binds to calcium, so that can explain the development of tetany or hypocalcemia in a patient. The correct answer for this question would be option number C. So it's hypernatremia, hyponatremia, then is hypocalcemia and hyperkalemia. So the answer would be given as hypocalcemia only. That was, yeah, we are coming to that crush injury patient after this only, and there we'll talk about what are the electrolyte derangements that would be present for crush injury, Vignesh. So this would be the answer for this question. Basically the question is regarding citrate toxicity. Yeah, hyper and hyponatremia is fine. We don't get sodium fluctuations, no. Citrate जब देते हैं तो citrate से calcium को bind करता है ना, so it causes redistribution of calcium, and citrate directly also binds to calcium. The reason why we add citrate is to prevent the blood from clotting now. So if you add too much of this, because you're given 4 units in a very little time, so that's why the tetany manifestations can be occurring in a patient. Fine. So we'll come to that question on the crush injury part and the electrolyte imbalance. Then we have this patient of ptosis with a diurnal variation, and chest X-ray shows a CT chest is showing mediastinal mass. No, hyperthermia is a separate question on thyroid storm that will come in a second. So there's a question on a mediastinal mass identified as a thymus gland cancer. Did they really mention the word thymus gland cancer? I mean, I expect them to say words like thymoma or like thymic hyperplasia like that. Did they really mention the word thymus gland cancer? Okay, acetylcholinesterase, fine. One of the options would be fine, acetylcholinesterase. Okay, so fine. Postsynaptic acetylcholine receptor, fine. Instead of this, it would be acetylcholine. Postsynaptic acetylcholine receptor, got it. Rest is fine, guys. Voltage gated calcium channels, then it's gonna be presynaptic and a postsynaptic. So yep, absolutely. Yes, we'll have to answer this as post. Myasthenia gravis is anywhere disorder of postsynaptic manifestation. Okay, at the motor end plate. Yes, that's a good input. Acetylcholine receptor at the motor end plate. So it means the same only, no? Whether I say motor end plate or whether I say at the neuromuscular junction, the input would be perfectly fine. If I'm having a diurnal variation with the symptoms tending to increase towards the evening hours, that's what you mean by the word, yeah, acetylcholine action of the motor end plate. Got it? I mean, it's not the word NMJ. It is like acetylcholine receptor at the motor end plate. But then acetylcholine receptors are the ones which would be affected in this patient. Yep, we'll go by option number B in this case. Shamim, can you comment on what channel are you mentioning an antibody against a muscarinic? Okay, fine. The MI patient is having a hypotension. That's perfect. If that goes more favor of myocardial infarction as compared to pericarditis. So just add that there, the word hypotension for this patient as well. That gives more credibility to us having reciprocal changes and simultaneously mention regarding the fact that there's a hypotension present. Okay, so antibody muscarinic. Okay, fine. I get that anti-muscle specific specific kinase antibody. That could be maybe one of the options that would be given in the question. Okay, fine. We are sorted for this one. The basic point is that acetylcholine will not be able to act at its receptor. So that would be the language post-synaptic. If it is mentioned is great. Otherwise, we'll just say that it is the antibody against the at the not at the pre-junction but at the post-junction level. Okay. You can what you can do is close the video and start it again, and the audio part will improve slightly better. Okay, we have this 35-year-old woman with progressive limb weakness for past 1 year. There are muscle fasciculations and hypertonia along with sensory system being intact. So what we are having is a lower motor neuron manifestation and upper motor neuron manifestation, and the sensory system in the patient is intact. The combination of the two will help us come to the conclusion that this patient is having amyotrophic lateral sclerosis. I know the fact that there are two questions on amyotrophic lateral sclerosis. One is from the pathology perspective, that SOD1 or superoxide dismutase, but for this one, it would be ALS as an answer only. Okay. Yeah, doctor, I mean, the disease would remain the same only, so it's not going to change much. Yeah, muscle wasting. Okay, I'll add muscle weakness and muscle wasting. Okay. In the description of the question, he tried to mention lower motor as well as the upper motor neuron manifestations. Okay, I'll add that. On examination, tongue weakness is also present. Okay. Fine, great. Not a problem. Happy to know that you're joining in from while you're traveling, but yep. Okay, so we are sorted for this one, guys. The answer will be option number A, and we can move on to the next one. A very interesting one, actually, that there was a symmetrical leg weakness, areflexia, and the person had died a couple of weeks ago. So he himself mentioned Guillain-Barré syndrome in the question, and then he mentioned regarding what is going to happen in the patient. Yes, guys, was GBS given in the question? Okay. GBS is given in the question, no? So the disease will be not demyelination of spinal cord, it's demyelination of the nerve roots, no? It is the demyelination of the nerve roots which is happening. The name of the disease is AIDP, that would be acute inflammatory demyelinating polyneuropathy. So we are talking about nerves being affected, no? Yes. So considering demyelination, antibodies against oligodendrocytes. Okay, that is a little surprising because of antibodies against oligodendrocytes. Fine, I'll mention that. I mean, that would not anyway fit into the discussion because if we are talking about oligodendrocytes, we are talking about the brain, we're talking about multiple sclerosis. Okay, fine. Quickly, let me know regarding the options as well. A and B fibers, B fibers. Was it A and B or was it like A beta? Yeah, that would be multiple sclerosis only. As long as it is arm weakness and areflexia, we'll think in terms of Guillain-Barré syndrome only. Okay. Okay, it was A beta, right? A beta tha na. So just correct that, A beta. Then another option was demyelination of B fibers. Was it B fiber or beta fiber? There's nothing like a beta fiber. No, it is the B fiber. So it is gonna be like, I'll just rephrase this. This is not A B fiber. This would mean A beta. Yes, yes, yes. It was A beta. Fine, guys. I mean, mota wala nerve fibers are affected in Guillain-Barré syndrome. No, it's not the chota wala nerve fibers. It's like thick nerve fibers which are affected, or those are the ones which would be demyelinated in this particular case. Okay. So fine, guys, the answer for this would be option number A only. The basic logic is that thick wala nerve fibers are affected, not the thin wala nerve fibers. And B nerve fibers are like preganglionic autonomic fibers, so it would be affected. Okay, and the answer for this would be option number A. It was ST elevation. Yeah, that is what I'm saying. No, if it is ST elevation in the limb leads in a patient, and simultaneously, if it's lead number one that is involved, it would be anterable MI. For inferior MI to occur and inferior lateral myocardial infarction to occur in a patient, then changes should be coming in not V1 and V2 and V3, V4. No, it should be V5 and V6 that should be coming. या मेघना, दैट्स व्हाट आई एम ट्राइंग टू से, दोज आर रेसिप्रोकल चेंजेस, नो उल्टा चेंज हो जाएगा ना कि एमआई में जहाँ पे डैमेज होता है उसका उल्टा वाला चेंज होगा, दैट वुड बी फाउंड इन लीड नंबर 2 and 3 ऑल्सो. Okay, A beta is what I'm thinking, guys. Perfectly fine. We move to the next one where we have a patient with cough and a weight loss. The biopsy is showing in this case expression of chromogranin and synaptophysin. So the cancer that we're thinking in this particular case is oat cell cancer of the lung. Small cell cancer of the lung, the commonest paraneoplastic manifestation that we see would be SIADH. That's mainly based on the biopsy of the lung mass, which is given in this case. Okay, smoking is given in the question. Cool. Fine, we are sorted for this one. This, I think, was one of the easiest ones in the entire paper. Palpitations, headache, sweating, BP being elevated, 24-hour urinary metanephrine values are elevated. Finally, I hope they have come to the metanephrine. You know, all the time they used to talk about Van-Eyl mandelic acid levels, and now they have changed it over to metanephrine levels. So, yeah, pheochromocytoma is the correct one in this particular case, but I'm happy that they finally graduated to metanephrine from Van-Eyl mandelic acid levels. Fine. Then is a patient with the osteoarthritis. Uh, he is taking ibuprofen for last 3 months and there's a occult GI bleeding. Let me know if this word was present. Uh, Occult GI bleeding. Was it like melena? Was it fresh blood in the stool? Was it occult GI bleeding? Yeah, Wilson is pretty straightforward. Liver wala na, that is okay. I think the pathologist has already discussed it, so that would not be a challenge anymore. फाइन, मेरा क्वेश्चन सिर्फ यही है कि एज लॉन्ग एज लोअर जो है ब्लीडिंग हो रहा है पेशेंट को, मतलब मलेना इज एक्चुअली एन अपर जो है ब्लीड ओनली, बट इट कम्स फ्रॉम द लोअर पार्ट ऑफ द इंटेस्टाइन, दैट इज ओके. बट द बेसिक पॉइंट इज द पेशेंट वुड बी हैविंग less prostaglandins, and the prostaglandin in the stomach would be prostaglandin E2 and prostacyclin, that is prostaglandin I2. They are the ones which help in production of mucus and bicarbonate. So the production of, by taking painkiller is lesser. That's why there would be erosive gastritis. I mean, the question is talking about a patient using painkillers for 3 months. That's going to contribute to development of erosive gastritis, and that erosive gastritis will explain that presence of occult blood in the patient. Yeah, the security of the mucosa. Okay, right. So he did mention the word mucosa there. Fine, I'll add that in point number A, but then mucosal security is lesser in a sense that there would be less defense. I mean, it's not more acid, it is the less defense that is present. Okay. Yeah. Okay, mucosal barrier reduction. I'll just add it only, less I forget it. Production reduced with decrease in mucosal barrier. That makes sense, doctor. Option number A is a perfectly great one. Next one is about a HIV positive patient with chronic diarrhea. I want to know about the size of the cyst. People just told me it was a double-digit cyst. So if it's small one, then the answers are gonna change. So let me know regarding the dimensions of the cyst as well. Okay, 10 millimeter. Okay, CD4 count was given. So quick comment about the CD4 counts, and the size was 22. So 10 by 20. As long as it is in double digits, no, then it is gonna be Isospora belli only. As long as it is एक single digit होता है ना, 4 by 6, 5 by 6, something like that I'm saying, right? 6 by 10, something like that. So if it is like both values in double digits, then both, okay, dual. Okay, that's a good input. Dual because if it's gonna be oval elliptical with dual, I think we discussed that in the cut short in the physical class as well, the dual image that is present. So dual sporocytes would make it answer as cystoisospora. The answer for this would be option number B. Yeah, now the CD4 count is inconsequential, guys. I mean, it doesn't matter. It is just that if we are talking about a dual sporocyst described, then this answer would be answered as cystoisospora. Exactly. As long as it is a dual one, cystoisospora is the correct answer for this one. Yes. Yeah, that is what I have also said, cystoisospora for the same thing. Otherwise, I would have also answered this as cryptosporidium. It was single digits one. Fine, got it. 16, 20, and 10, 15. Got it. That's the basic hack, no? That if it's in single digits, it's cryptosporidium. If it's in double digits, it's cystoisospora. Okay, great. This is the question I wanted to talk about regarding thyroid storm. Like a patient is that of hyperthyroidism and the patient is not on medication but is scheduled for total thyroidectomy when the pre-anesthetic checkup was not done properly. So the patient is at risk for development of thyroid storm, whether we are planning surgery or whether we are planning to give radioactive iodine, that is thyroid ablation, to this patient. We need to first ensure that the patient will become euthyroid, and leading complication that can occur during surgery would be that thyroid hormones will have a sympathomimetic overdrive. This is going to contribute to development of arrhythmias in these patients. Okay, just surgery. So it was total thyroidectomy, word is not given. If the patient is scheduled for surgery, yeah, intraoperatively, what is the leading complication is what you want to get. Fine, got it. There can be two possibilities here. One can be hyperthermia and second is going to be arrhythmia. Among the two, which is like more lethal and more of concern, would be arrhythmia occurring in this patient, because that could be a disaster situation. Okay, fine. Not hypothyroidism. It is gonna be a thyroid storm. So thyroid surgery. Yeah, yeah, got it, got it. Thyroid total thyroidectomy is thyroid surgery only, no? So arrhythmia can occur at the time of surgery, primarily because of a sympathomimetic drive that is increasing. So that can explain these patients ending up with either sinus tachycardia or degenerate into atrial fibrillation as well. Fine. Hypothermia, because no, not hypothermia. It is. Fine, I think we are sorted for this one. Pulmonary embolism in the option. Okay, fine. I'll put it or place it there, right? One of them that is present is PE, pulmonary embolism. Okay. We have this male deep-seated retroorbital pain or cluster headache. Was the word cluster headache given in the question, or you had to interpret this? Yeah. Yes, guys, was the word cluster headache given in the question? No? Then what we'll do is we will give oxygen to the patient. No, it is mainly oxygen which is to be given. Along with oxygen, we have to give triptans. I hope the question was not on prevention. I mean, I hope that I got it as what is the best management for this case. So that would be answered as, yeah, abortive treatment. Okay, best abortive treatment. Fine. So we will be giving high flow oxygen, and along with this hypoplasmic oxygen. Okay. Lithium is for preventive aspects, no, because they can be suicidal tendency in these patients, or they can hurt their eyeball because the pain is very, very intense. So the question is about the cluster headache. Yes, got it, guys. Abortive is gonna be like traditionally abortive is triptans, but he removed the triptan from the discussion, so it is oxygen which would be answered, and that would be high flow oxygen that we give. So it's a standard table which is given for sunset and has to be remembered. Yeah, got it. Answer would be B for this one. The next one talks about a patient with hypertension and a hypokalemic metabolic alkalosis. There's a mass over the kidney. Did he write the word adrenal adenoma, or was it mass over the kidney with changes in aldosterone renin ratio? And what is the best one for management of this patient? No, that was a totally separate question, guys. There was no triptan in this question. Absolutely sure about it. I had a chat with a lot of people. There's a separate question on related in pharmacology. That's perfectly fine. But for abortive treatment here, it's oxygen which would be given. Okay, so mass over the kidney, which would be present in this case. Okay, there was triptan that was given in this question. Fine. There's a mass that is present over the kidney that is 1.5 centimeter. Fine. Guys, we are dealing with the adrenal adenoma. No, if I'm dealing with the adrenal mass, then I'm dealing with the adrenal adenoma. So I have to get rid of it. No, so I need to go for an adrenalectomy in this particular case. ACTH stimulation test is done for Addison disease, and dexamethasone suppression is done for Cushing disease. We are dealing with a case of Conn syndrome, where he has himself mentioned hypertension with hypokalemic alkalosis, which tells me that the aldosterone values are elevated in this case. We will have to treat the patient with adrenalectomy in this patient. Okay, he's saying what first pucha tha. Yeah, the basic thing is first abortive treatment would always be given as oxygen for management of these patients. It's high flow oxygen that we give to these patients basically. So curandero. Okay, that was a good input from your side. Fine. Answer is B to this one. हाँ वो मैं डिस्कस कर लिया यार. I mean multiple times have we taken care of that kind of a discussion where like we assume that this could be one of the possibilities in the question. Adrenal venous sampling was in the options. Okay. So, Doc, that I discussed in that mock test, no? So, adrenal venous sampling is the input that you were saying that is for lateralization. I mean, that is to find out where the tumor is present, basically. Okay, that's an interesting one. It changes the entire game, right? If he says what is the next best step for management of this patient, and adrenal venous sampling is also given, then we'll have to think in terms of answer as adrenal venous sampling, no? Then it would not be adrenalectomy because first we need to find out which side the tumor is present. Is it on the left or is it on the right? Though I mean the CT scan is fine, it is giving us, but then if he says next step, then it would be adrenalectomy. Before adrenalectomy, adrenal mass sampling would be done. We are having a patient with chronic hypercalcemia for last 1.5 years. Was this given 1.5 years or was it a short history? Because that changes the entire perspective. PTH levels are normal, so parathyroid adenoma, hyperplasia, that is out of this part. Yeah, if it is like best treatment, adrenalectomy is the best one. I think I'll go by like what I said initially. For any patient having a Conn syndrome, mostly he'll ask you like what is to be done, and let's not get into too much of specifics there. For any patient having a adrenal adenoma, ultimately with elevated ARR ratio, we need to go for adrenalectomy as the best treatment. Okay. 1.5 years with PTH being elevated. Fine, guys. So answer cannot be parathyroid hyperplasia. CKD cannot be the answer because calcium is low. You are left between malignancy and sarcoidosis. Malignancy will be having a much more faster course. I mean, you don't have a lung cancer patient lingering on for 1.5 years. No, it would not be malignancy, guys. It's not malignancy. Malignancy will always have a fast progression. No, within 6 months, patient would be dead. Squamous cell carcinoma will cause hemoptysis. It will cause a cavity formation. It will cause extensive damage. So the answer in this case would be given as sarcoidosis. It is not hypercalcemia malignancy, it would be given as sarcoidosis. Yeah, exactly. It is basically the fact that PTH levels can be normal because PTH levels, original PTH RP would be elevated in malignancy, no? But in sarcoidosis, the PTH levels will decrease because in this particular patient, what will happen is that the granulomas will be synthesizing 125 dihydroxycholecalciferol. So because of indigenous vitamin D production, the calcium values will go up and therefore the PTH values will decrease in this patient. So considering a long history, guys, we'll go by sarcoidosis as an answer and not malignancy, for which you need hospitalization, for which the manifestations PTH can be decreased also. Fine, that is okay, guys. PTH levels can be low. Again, feedback mechanism. No? That is what I'm trying to tell you. Sarcoidosis में जो PTH का value है वो धीरे धीरे कम हो जाएगा ना, because sarcoidosis के जो granulomas होते हैं वो vitamin D3 बनाएंगे. So if it is vitamin D3 that will be produced in this particular case, then the calcium values will rise and that will affect the PTH values in a patient. So they can be normal, they can be low. That's perfectly okay by us. But considering that this would be malignancy, there would be always a very, very fast progression. A female patient presents with amenorrhea and galactorrhea, and there's a elevated serum prolactin with the MRI showing a pituitary adenoma. So I think they love pituitary adenoma. One was that visual field deficit of a bitemporal hemianopia, and second is regarding the serum prolactin being elevated. And then we will be going ahead with the bromocriptine in this patient. So the answer for this question would be given as option number A. Guys, I'll try to address as many doubts as possible. I mean, that's my job, right? To let you know whatever is the right thought process. Okay, so we are sorted for this one. The answer is option number A for bromocriptine. Okay. Okay, pituitary adenoma compressing an optic chiasma would be bitemporal hemianopia. So the answer would be option number A. Then is this woman, she's having weakness, back pain, repeated infections, and an M spike on serum electrophoresis. That tells me that I'm dealing with a case of multiple myeloma. And the question is with respect to what will be deciding the prognosis in this patient. So for prognosis, the most important thing that I've said multiple times is beta-2 microglobulin levels in the urine of this patient would be checked. So what we will do in this patient is check for the levels of albumin, and along with this albumin, it is going to be beta-2 microglobulin. No, it is not easy. We are not twisting any question and it's not framing. It is just that now things are becoming much more easier when I discuss, when I discuss in even a live test and discussion, people are able to understand things relatively better. But in the actual exam, they are not able to comprehend that. Okay, so the correct answer in this case is option number D. That would be albumin and beta 2 microglobulin. And our job is not to twist any MCQ. What we do is we go by the facts whichever are asked, and the question is not on IgG levels. This question is not IgG because we're talking about prognosis in a patient. And multiple myeloma, the prognostic index, international prognostic scoring is albumin and beta 2 microglobulin levels. Okay, we move to the next one regarding hepatitis B patient. He has given a case of surface antigen positive and IgG class of antibody to the core antigen present. So we are dealing with a case of chronic hepatitis B. देखो कुछ तो गलत होंगे ना यार, स्टार्टिंग वाले तो सारे लाइन से आई थिंक 10-12 तो सारे लाइन से ही सही है ना आपके, राइट? तो फिर बीच में कुछ कुछ कम एक आधा गलत हो ही सकता है. सो इट्स लाइक अ प्रोसेस, learning unlearning process that we have. We have is a question on a patient who's having chronic hepatitis B, and he says, what is the drug that we are using in this case? Let me know if tenofovir and entecavir in the options. No tenofovir and no entecavir in the options. So answer would be lamivudine. That's one of the old drugs that is used for management of this patient. Acute hepatitis, sir, acute hepatitis में तो कोई treatment ही नहीं देते ना. And it's only in chronic hepatitis that the treatment is given. Acute hepatitis का तो self-limiting course होता है ना, so we don't give any treatment in acute hepatitis. It is lamivudine. तीन ही दवाइयाँ होती है, tenofovir होता है, entecavir होता है और lamivudine होता है. So answer would be lamivudine only for this one. And acute hepatitis का तो इलाज ही नहीं करते ना. We go for self-limiting course in that. Okay, Miravirok. That is what we use in HIV, no? Okay, fine. Now we come to that crush injury. एंटिका वीर बोल रहे हो, ई एल बी वीर आपने बोला शुभांगी, तो वो जरा थोड़ा मेंशन कर देना सर. एक्यूट हेपेटाइटिस बी में भी ना अगर फल्मिनेंट की तरफ जाता है ना पेशेंट, तो हम फिर भी ट्रीटमेंट दे सकते हैं. सो इट इज लाइक क्रॉनिक हेपेटाइटिस बी इज वेयर वी यूजुअली गिव ट्रीटमेंट. एक्यूट हेपेटाइटिस बी विद प्रोग्रेशन टू फल्मिनेंट वी डू गिव ट्रीटमेंट, बट आंसर वुड रिमेन लैमिवुडीन ओनली. Okay, albumin and beta 2 microglobulin. Saransh, I got your point. I got your point. Spot on. There would be hemoglobin in one of the options. I'll just put that there. Fine, guys. Patient of road traffic accident is having a red color urine due to myoglobinuria. So that tells me about crush injury. And in these patients, unfortunately, there would be a acute tubular necrosis and a renal shutdown. And when we have a renal shutdown in a patient, then the electrolyte imbalance that would be occurring in this patient would be a hyperkalemia. Potassium values are gonna spike in any patient whenever there is gonna be a renal shutdown in the patient. Okay, hypercalcemia also in the options. Fine, guys. And they can create any number of unwanted data to make us get confused. It's phosphate that would be elevated and calcium that will become relatively low. Okay, fine, guys. Answer to this question is option number B. तीन ही दवाइयाँ होती हैं. That is entecavir, tenofovir, and then is lamivudine. Okay, do let me about this question. FeNA values was given to be less than 1% and urine osmolarity is 500. Or do you want to change those values? FeNA is fractional excretion of sodium. A guy had a road traffic accident followed by renal shutdown. And then he's talked about the type of renal failure present there. Pre-renal, post-renal, renal variety like that. Okay. Okay, 350. Fine. I was looking for that value actually, 350. Okay, urinary sodium was also given. Fine, 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 fine. Urinary sodium of 40. Yes, yes, absolutely. Fine, guys, got it. I mean, this would be a patient who would be having his. Oh, great, great, guys. So considering that there's a renal shutdown in a patient, we'll first go by diagnosis as a pre-renal variety because any patient. Okay, I'll make it 300, guys. I'll make it 300. See, there are two things which I want you to understand. One possibility is that the person could end up with development of acute tubular necrosis as well. I mean, that is what the parameters are, what you're trying to tell me here. Quickly comment regarding, guys, whether the FINA value was less than 1% or was it more than 1%? The fractional excretion of sodium values doesn't matter. We'll figure out the final input there. But fractional excretion of sodium values for this question, less than 1%, more than 1%. Can I have? Yeah, got it, doctor. I got it perfectly fine. I understand the language of the question is not like this. They've asked, they mentioned pre-renal themselves, and they're asking you the input that has to be selected. That is why I'm just looking at the value here. Okay, so what I'm saying is that if you look at these values, all of these values that are given usually go in favor of ATN, that is acute tubular necrosis in a patient. So though the framing of the question that I mentioned at the moment is not right, but the values that you have given at the moment here with respect to FINA, urinary osmolality, and then urinary sodium values, they all go in favor of ATN or acute tubular necrosis in a patient. Okay, which one is true for pre-renal? I don't think so. They gave values and then they asked, because they have asked select the correct set which would be present. So the set that would be present would not be for pre-renal variety. It is for acute tubular necrosis. Okay. We have chalo, we will I need to frame this relatively better. We'll put that find the final solution in the app. So there's a patient in intensive care unit, and there's a failed attempts on subclavian catheterization. The BP drops and the pulse rises in a patient. Let me know regarding this word subclavian catheterization given in a question, and we can mention them subsequently. If it's pre-renal, no, the urinary sodium values should be high, and the urinary sodium values, I mean, urinary sodium should be low, and urine osmolality will be high, but the findings go in favor of rather ATM. Okay, so as long as subclavian catheterization is present in a patient, that would be pneumothorax. I'll repeat my statement. Why not pre-renal is because urinary sodium is high, 40, and the urine osmolality is 300. For the pre-renal variety, you need to have is a low urinary sodium because everything gets reabsorbed. And at the same time, you also need to have is, I mean, the value of urine osmolality is very concentrated for the pre-renal variety. Okay, if question mentions pre-renal, then it's a separate thing. Then we'll have to select according to the options. Know that FINA value less than 1 and the remaining set will have to be answered. Fine, guys. I think the previous question, the framing part has to be taken care of. But this one is relatively easy. Breathlessness in a patient. And then there is a drop in the blood pressure. So it is pneumothorax. The next question talks about a road traffic accident. The CT head of the patient was normal, and then the patient died after a couple of days, and we show multiple punctured hemorrhages. Any road traffic accident with CT scan being normal is always going to be diffuse axonal injury because there's going to be like a shearing stress on the brain. And okay, DAI in this. Okay, breathing difficulty. Okay, this was that after 20 minutes. Fine. After 20 minutes, the patient is having issues. Symptoms are coming after 20 minutes. Got it. Then is DAI, that is diffuse axonal injury. The answer would be B. This is a patient who's come with fever and altered sensorium, and the peripheral smear shows multiple ring stages. Let me know regarding the peripheral smear findings that were given for this. I know you'll jump on to artesunate. That's understandable in an Indian scenario with fever. Yeah, that's what I've written also. No, subclavian failure, right? Failed attempt. No, that's what I've written. Failed attempt to subclavian catheterization. So what has happened is that the catheter has punctured the lung. That's what they attempt by the word failed attempt, right? So that would contribute to a pneumothorax. Okay, Saransh, I'll take a snapshot of that or the value. Okay, fine. Okay, falciparum was given in the question, and then he is mentioned regarding, Vignesh, I'm coming to that. The answer is basal ganglia. Putamen is a basal ganglia, na bache? So that question is coming up. Like your question mentioned intracerebral hemorrhage, option putamen is not there. Answer would be given as basal ganglia. Yeah, ballooning of the internal capsule was present, right? Patient was from Assam. Okay. So considering the state, considering falciparum malaria given in a question, I'll be treating this as a case of complicated malaria because brain is getting involved, and therefore I need to give artesunate for management of this patient. Yes, Doc EM, I got your question regarding those values, so we'll have to select them. No, no, doctor, the answer is not hydroxyurea. It is voxelotor to prevent hemolytic episodes from occurring. Artesunate for patient who's having complicated malaria. Then is human papilloma virus is strongly associated with which of the following? या quinine resistance होगा ना, because असम में तो वैसे भी quinine resistance हो गई ना patient में. If he has himself mentioned quinine resistance, that would make it even much more easier for us. Okay, HPV would be strongly related to oropharyngeal cancer. Falciparum is given in the options, Faisal. I included that. I mean, whether it's a peripheral ring stage, multiple ring stage, falciparum, both imply the same. Okay, bache. So we are on the 33rd question at the moment. A 12-year-old guy with diarrhea, constipation, malabsorption, and pigmentation on the lips and the mouth. So we're talking about Peutz-Jeghers syndrome in this particular case. Okay, fine. भाई अच्छी अच्छी बातें बोला करो. Laryngeal के साथ strong association in Ranadhir Babu, you have a very good point. Why can't it be associated with laryngeal cancer? I mean, I raised that in my Zoom session as well, that it can be laryngeal cancer as well, but strong association is with oropharyngeal cancer. Okay, the answer would be PGS. Then is defect of Bernard-Soulier syndrome. The hint is Bernard-Soulier. The problem is the sticking part, the adhesion part that is defective. So, okay, buccal mucosa. Okay, the word is buccal mucosa. On the pigmentation. Yes. Factor 8 was there. I think there are two questions on, one was a question on hemophilia also, but I'll take it at whatever you're saying, including a factor 8 deficiency in this case. Yes, guys, it's just presence of mind and prayers that would sail you through. Fine. What I'm saying about Bernard-Soulier is that it's an addition defect. Addition defect would mean that a 1B defect would be present in this case. Option number A would be for Glanzmann thrombocythemia. Okay, okay, fine. If cut short, whatever that helped, yeah, we took so many sessions this time. Cut short was there, then we had this image base, and we had one-liners. I mean, there's a lot of information coming in. Okay, we are sorted for this one. हाँ जी मैंने चेंज कर दिया अजीज. I get your point. I changed that to factor 8 deficiency. Okay. Then is a patient with shortness of breath and fatigue, and an X-ray was done, and it was showing multiple areas of these popcorn kind of calcifications that were coming at multiple sites. So considering a popcorn calcification in an occupational lung disease case. Yeah, I have included that, Ranadir. I've included that question there. Subsequently, you will see it flashing on the screen very soon. The question will mention regarding a patient having a kid having falling down, and then there's a knee bleeding, and the apidity of the patient is deranged. So that hemophilia part is what I've taken care of. Okay, calcification is on the hilar side in this particular case. Fine. If it is a hilar calcification, then यार एक्चुअली क्या होता है ना, जो कैल्सिफिकेशन होती है ना वो एस्बेस्टोस के फेवर में जाती है, क्योंकि वो तो एग शेल कैल्सिफिकेशन होती है ना, बड़े बड़े लिम्फ नोड्स होने चाहिए. सिलिकोसिस विल ऑलवेज बी हैविंग इज अ हाइलर लिम्फेडिनोपैथी. Okay. You need to have a actual calcification for this. So yeah, I mean, if the calcification is around the lymph nodes, then I take your point. The answer would be given as silicosis. But if we are having calcification in the periphery towards the pleura, because we read that one, a pleural plaque calcification is a feature of that would be asbestosis. Okay. सीमेंट फैक्ट्री वेक्टर मुझे लगता नहीं है दे रखा था, you know that I don't think so that that occupation was given, but even if it is given, it will not change. It is the location of the calcification that will determine. So in your x-ray, if it was a perihilar calcification, then you will say, okay, I'm dealing with a case of silicosis, point taken, and you get a mark for it. But if there was no hilar lymphadenopathy with multiple spotted peripheral calcifications present, because pleura तो बाहर की तरफ होता है ना, so if you are having a pleural calcification, then it would be asbestosis. Okay. यस, सीमेंट फैक्ट्री वॉज बहुत अलग था यार, सैंड माइनिंग और वो वाला वो हो गया, पैथोलॉजिस्ट ने डिस्कस कर लिए हैं वो वाले। मैं एक्सरे के पॉइंट ऑफ व्यू से बोल रहा हूँ, अगर लिम्फ नोड के आसपास कैल्सिफिकेशन है या पेरिफेरल है, दैट विल चेंज द आंसर इन द क्वेश्चन। हाँ जी हाँ जी, समझ गया मैं। क्यूरेंडेरो, आई गॉट योर पॉइंट। इफ इट इज द सैंड माइनर गिवन, सैंड माइनर and also mentions hilar lymphadenopathy and a calcification, then we'll go by silicosis only. So take on a point for it. I mean, you get one full mark for that. And if it is asbestosis, then it is peripheral. Okay, so asbestosis, the next one is about a dentist. Every year we debate about asbestosis silicosis. Dentist is developing a vesicles on the index finger. He would have tested a patient who would be having lesions on his lips without touching glove, without using gloves, and this is called as Whitlow. Whitlow would be an occupational risk in doctors. When you touch these cold blisters on the lips of a patient without using gloves, then there can be painful lesion on the picture of a patient, and then the answer would be given as herpes simplex virus. The answer for this question would be option number B. Yes, Aziz, I take your point for this. Whitlow tha, that is herpetic Whitlow basically is what we are talking about at the moment. The cold source lesions should not be touched without using gloves is the learning point there. Okay, so we are having a patient in which, I mean, this is the keyword that I got, basal crepitations. You know, if this is given, cool, otherwise we think that this question is an exaggeration of somebody's thought process. But one guy that is very dear to me, he basically was very insistent about this question, that shortness of breath for 6 months and basal and respiratory crepitations was given. Okay, so help me out with the options here. Okay, help me out with the options, please. Fine, basal and respiratory crepitations. That is interstitial lung disease only, no? Help me out with the options, guys. Okay, gargling. Uh, okay, consolidation. Fine. I'll keep on putting options. One of them is consolidation. Another option would have been pleural effusion, right? Okay. Fine, get it. Pleural effusion, consolidation, core pulmonary. वो तो सिगरेट स्मोकर में होता ना, तो इससे तो बाहर ही कर दो. ओके, स्क्लेरोडर्मा. फाइन. तब भी लंग फाइब्रोसिस की तरफ ही जा रहा है ना बच्चे. स्क्लेरोडर्मा है, hand stiffness है, so that is all gonna contribute to lung involvement in a patient, no? So there would be some pulmonary fibrosis occurring in a patient. History of scleroderma understandable, बच्चे. What I'm trying to say is that basilar crepitations, this is the key word for solving the question, that if there's a history of scleroderma, that makes it more going in favor of that interstitial lung disease in a patient. Yes. Gurgling, okay. No, there's nothing like gurgling actually, but yeah, I mean, even if we change that crepitations to some distinct sound that is coming up in a patient, considering scleroderma history, scleroderma का तो मतलब ही यही होता है ना बच्चे, fibrosis is present in the options. Fine, guys. So we'll settle at option number C for this question. The original question of mine is almost similar to what is finally turned out to be. The basic concept is scleroderma contributes to lung fibrosis. Okay, fine. We are sorted with fibrosis part here. Okay, the very interesting question that is coming up is the fracture of the shaft of femur. मुझे बता देना डी डायमर इज एलिवेटेड क्वेश्चन में लिखा था या नहीं लिखा था. Just let me know, in a fracture of the shaft of the femur in the question, was there any mention of elevated D dimer assay or not? Okay. Okay, so if it is gonna be D dimer that is elevated, yeah, saturation of oxygen is gonna be 85%. Fine. Okay, so let me explain. अगर डी डायमर ऐसे लिखा है तो वी आर थिंकिंग इन टर्म्स ऑफ पल्मरी एम्बोलिज्म इन द पेशेंट. अगर डी डायमर ऐसे नहीं है देन द आंसर इज स्ट्रेट फॉरवर्ड, दैट इज फैट एम्बोलिज्म सिंड्रोम. I will go by option answer A only, considering that I think this should be a straightforward question. Guy had a fracture of the shaft of femur. There's a drop in saturation on the third day, so we'll think in terms of possibility of fat embolism. Though ideally, there should be mention of GERD criteria. So there should be CNS manifestations given. There should be mention of at least things like PTK present in the patient. But if it is not given, even then we'll give benefit of doubt to fat embolism as an answer. But if the word D dimer is present, then okay, Randir, you can let me know regarding another option in place of cor pulmonale. But anyway, the answer for ours would be lung fibrosis only. It can be नहीं 48 आवर्स का क्राइटेरिया नहीं होता है. देयर इज नथिंग लाइक अ 48 आवर्स का क्राइटेरिया. Sudden breathing difficulty, yeah, he develops shortness of breath, no, that is okay. Sudden onset shortness of breath in a patient. Okay, fine, let me know the other options. We are working out the answer to this question perfectly fine. Let me know the other options in this question. Okay, so there was no other embolism in the question, so that makes it easier for me to answer this. The answer would still be given as fat embolism in the question. फाइन गॉट इट. आई मीन बाकी सारों में किसी में भी कोई किसी भी प्रकार का एम्बोलिज्म क्वेश्चन में दिया नहीं था. Okay, so fine. I have given enough type for this one. Let's move to the next one, a long arm span. No, if you're listening for this for NEET PG, I want to tell you that if D dimer is elevated, then you don't answer as fat embolism, then your answer would be given as pulmonary thromboembolism. Okay, chalo, patient having a long arm span, hypermobile joints and a hypermobile lens. Obviously, the question stem would be longer. I need more input from you guys. I mean, the age of the patient and everything. But that's the key word. An arm span more than the height of a patient, and even the guy is gonna be tall or the girl is gonna be tall. So what we'll think in terms of is Marfan syndrome and a fibrillin defect in this case. Move on to the next one. Hips arrhythmia. That's a easy one. Chalo. In rheumatic fever, I think that then we're discussing something else, because if it's gonna be rheumatic fever and we are giving, even then we'll not give aspirin for like lifelong basis, or it's okay. Okay, so hips arrhythmia question came. This would be ACTS that would be used in this patient. Grossly chaotic pattern, big polyspikes that could be present in a patient. So ACTH would be given. Lots of time the question would be for okay, Perumal, you had good inputs there. 3 months, 6 months, lifelong, and clopidogrel with aspirin. Great. So I get it, Doc. What we'll do is, I missed that video link. Fine. There's a separate one, Doctor. Coronary artery aneurysms in a patient. Then we're talking about aspirin. Second is a question on rheumatic fever, where the aspirin requirement would be done. Okay, so I think we are discussing with a separate one, right? If you're talking about rheumatic fever and there's like valves and aspirin that would be present in a patient, then it was a separate thing to be present. But for Kawasaki, if it's the coronary artery aneurysm in rheumatic fever, we don't have a coronary artery aneurysm. No, the question that we're discussing is a coronary artery aneurysm. That's only with Kawasaki disease. Okay, tetralogy of Fallot was, I think, much more easier one. And yes, this is what somebody was mentioning कि सर brain hemorrhage आया था, and brain hemorrhage की वजह से patient की CNS bleed की location पूछी थी. That would be basal ganglia, that is the area of the putamen. Yes, got it. Rheumatic fever with carditis is the question. Fine. Got it, doc. That I will be adding to my discussion subsequently, where there were options were ranging from valve replacement to indications for giving aspirin in a patient, and versus a question on Kawasaki disease. Great. So two different ones. Okay, severe carditis. Yes, yes, got up enough. I got the point. इसमें बताना पिन पॉइंट पीपल्स था क्या क्वेश्चन में? What do you see in the patient presented with these symptoms, not the location? Okay. Yeah, if it is hypertensive patient with a brain hemorrhage, he'll say the location of bleed only, no? No, pinpoint तो फिर forensic medicine पे question आ जाएगा ना, pinpoint pupils with respect to a person who had uh, I mean that poisoning that could be given, heroin poisoning that could be given. Okay, Rutvik, thanks for that input. I was looking for that question. Severe carditis and rheumatic fever, that's gonna be glucocorticoids, aspirin, and valve replacement. Got it. Fine. So for severe carditis, we will give steroids. I just want to clarify that if it's a severe carditis in a patient, then in rheumatic fever, it is steroids that would be given in the patient. Okay, fine, guys. So we are sorted for this one. Then is regarding undulant fever. He says, what is the management for this condition? So we'll give doxycycline with either rifampicin or along with doxycycline, we can be using is cotrimoxazole as well. So undulant fever is Malta fever basically. Let me know any history given, consumption, non-pasteurized milk, etc. Doctor, for rheumatic fever with carditis, no, if the valvular lesion is not given, we want to give steroids to the patient initially. Okay, fine. It's doxycycline with rifampicin for management of Malta fever. Okay, question had features of weight loss mimicking tuberculosis. Okay, fine, got it. So it was a case with respect to undulant fever. The symptoms were identical to that of tuberculosis, but then he mentioned the word undulant, describing the pattern of fever and asked the treatment for this question. Okay, night sweats in a patient. Yeah, got it, got it. I mean, as long as there is gonna be features of suggestive of tuberculosis along with a pattern of fever, the answer would change from tuberculosis to that of undulant. No, I don't think so. Pani Puri face, Pani Puri seller, ये वाला. Okay. ये पानी पूरी सेलर का बताना भाई क्या कहानी है. प्रखर अगर वैल्वुलर लीजन होता है फिर तो हम वैल्व रिप्लेसमेंट कर देंगे ना, अगर सिवियर वैल्वुलर लीजन है. अदरवाइज अगर वैल्व लीजन भी है तब भी पहला आंसर तो स्टेरॉइड ही रहेगा ना, ताकि हम उसके प्रोग्रेशन को रोक सकें. सो अगर वो सिवियर माइट्रल सिनोसिस बोलता है, सिवियर कार्डाइटिस बोल रहा है, तब भी डजंट मैटर, इट विल स्टिल रिमेन एज स्टेरॉइड्स फॉर द पेशेंट. ब्रुसेला करता क्या है? इट कॉजेज फीवर, इट्स प्रेजेंट्स लाइक टीबी, इट कॉजेज सिम्टम्स लाइक ट्यूबरकुलोसिस, लेकिन बुखार उतरता नहीं है, वीक्स ऑनवर्ड्स तक प्रेजेंट रहता है. इट्स मोर कॉमन इन पीपल हु आर टेकिंग नॉन पेस्चराइज्ड मिल्क एंड इज कॉमन फ्रॉम पीपल इन रूरल इंडिया. Okay. This was, I think, more of anesthesia question, train of four monitoring with the electrodes present on this particular area. If the image is correct, just let me know. Yeah, Pani Puri seller is a millionaire. Yeah, yeah, I get it. I get it. I think the pathologist has discussed that question. हाँ जी, ulnar nerve है इसका. The correct answer for this one would be option number B, because electrodes are placed on the ulnar nerve side only, na? Recording electrodes on the ulnar nerve, so you can test the movement of the thumb in this patient. The answer will be option number B. Okay, the next patient is having coileonychia, that is spoon-shaped nails. That would be a feature that is seen with Plummer-Vinson syndrome. Prophylaxis, we use verapamil. Abortive treatment, we give oxygen in the patient. Okay, answer would be A for this one. Then is about a classification for Barrett's esophagus. Okay, asymptomatic patient, AST, ostium secundum. Imtiaz, do let me know regarding the options in the question for that ASD. Patient 23, ostium secundum. We have to go for a device closure. But anyway, I'll note it down. 23-year-old guy, ASD, ostium secundum. The reason being that AST usually presents by second decade of life, and that can result in development of congestive heart failure or pulmonary artery hypertension in the patients. Okay. Yes, eco device closure. Yeah, yeah, eco guided device closure. Good one, man. That pediatrics question on pediatric cardiology was a good one. Okay, fine, got it. Not there. Fine. No, doctor, we usually give for something like 6 weeks. Fine, I got it, Bhavika. The next question talks about presentation of prinzmetal angina. Options may not match, but let me know regarding this woman who comes with chest pain, waking up in the morning, and pain is more in the winter months. सर्दी के महीने में चेस्ट पेन होता है. The presentation is query prinzmetal angina. Okay, age 32, no symptoms. Got it. Though the patient is asymptomatic, we will have to manage the patient anyway. Okay, no such question was mentioned. Fine, guys, I got it. Among the remaining two. So at the moment, it is how many reduced? 50 slides, no? So 48 are ones that I'm discussing. Okay, asthma symptoms and winter months. Okay. Abhinav says question was present. भाई था यार, one guy was very vocal about it कि prinzmetal angina का manifestation है और cold weather में manifestation हो रही है. Yes, 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 yes. वो asthma और उसके बीच में differentiate करना है. Got it, got it, got it. भाई there's a question related to winter months. अब उसमें वो है कि वो अस्थमा के बारे में पूछ रहा है. वो तो हम सस्पेक्ट कर रहे हैं ना कि प्रिंजमेटल एंजाइना है या नहीं है बेस्ड ऑन द सिम्टम्स इन अ पेशेंट. सर्दियों में दिक्कत ज्यादा होती है. अगर इफ इट्स टॉकिंग अबाउट ब्रीदिंग डिफिकल्टी देन विल थिंक इन टर्म्स ऑफ अस्थमा. इफ इट इज अ चेस्ट पेन मैनिफेस्टेशन विल थिंक इन टर्म्स ऑफ अस्थमा इन अ पेशेंट. सो फाइन, आई गॉट इट. आई मीन वी will modulate that subsequently. Barrett's esophagus is that Prague classification, no. And for prinzmetal angina, it would be acetylcholine-induced coronary vasoconstriction because normally acetylcholine causes vasodilation, but in prinzmetal angina, there is always a vasoconstriction present. Ranadir, can you comment upon the TTM test? Could you explain the TTM thing once again, please? Fine. So I think we are nearing towards our 50 mark very soon. I think this was in paper one. I'm not very sure. Abundant neutrophilia. Cold increase the symptoms. Okay, Saransh, got it. So there was a question related to cold exposure with respect to chest manifestations in a patient. Got it. Okay, got it. Fine, fine. In a treadmill. Right, right, right. Got it. She's exercising in cold weather and she's having development of chest pain. One. And then mast cells are activated due to cold weather. So it's not, it's a cardiac issue, doctor. So it would be main of acetylcholine based data. Okay, hi Paras. Good to see you here if you are the real Paras here. Fine. Abundant neutrophilia was a question that's present. The answer would be given as acute bacterial meningitis. And then we have a kid, sugar was normal. Okay. Okay, with salbutamol, yeah, that's what I'm saying. No, if the symptoms are improving with salbutamol, then we think in terms of asthma. If it's gonna be chest pain, then we are gonna think in terms of prinzmetal angina in the patient. हाँ, मतलब ज्यादा कंफ्यूज नहीं करेंगे यार. वो होता क्या है, कई बार ना सीएसएफ शुगर नॉर्मल इसलिए आ जाती है बिकॉज वी हैव स्टार्टेड आईवी फ्लूइड्स इन द पेशेंट आफ्टर बिफोर डूइंग लबर पंक्चर ना, बिकॉज रिससिटेशन ऑफ पेशेंट इज टू बी डन. सो समटाइम्स द सीएसएफ sugar can be normal also. The answer in this particular case would be given as because it is neutrophil, no doctor. Yeah, in that winter question, if symptoms improved with salbutamol kind even, I agree to that. Then answer would be given in favor of bronchial asthma only. Okay, fine. We have this. We have the 6-year-old kid. He's having pneumonia, statoria, and failure to gain weight. And considering that he's having pneumonia and he's having statoria, both manifestations are given, the lung manifestation and the GI manifestation. Okay, PMN. I'll change that. Polymorphonuclear cells. Yep. Considering that there is a combination of pneumonia and statoria in a patient, I'll go by sweat chloride, that is for cystic fibrosis, as an answer. Yes, quickly comment with respect to any changes that you would like to make for this question. Great, great. Okay, so we have an interesting one. Actually, nobody discussed that, so I thought I'll discuss it here. That a skin grafting is being performed, and this is with respect to immunocompromised patient. And after the skin grafting, there's the contracture and systemic symptoms developing in the patient. Okay, Adi. Uh, Gene analysis for this one. Okay. भाई ये बताओ, ये वाला जो पिछला सवाल था इसमें जीन एनालिसिस था सिस्टिक फाइब्रोसिस वाले में, सीएफ जीन एनालिसिस था कि नहीं था? And that changes everything, man. The most confirmatory diagnostic test would then be answered as gene analysis here. If it's gonna be cystic fibrosis, then it's gonna be gene analysis, right? Okay, so if no gene analysis, then it is okay. Then it is sweat chloride. We'll keep things simple, man. I don't think so. I'll get into gene analysis. Okay. हाँ, अगर अगर यहाँ पे जीन एनालिसिस है, so then we'll go by gene analysis now. If we're saying the best test for this question, for this patient of cystic fibrosis, and I'm saying about presence of gene analysis in the options, then I'll go with option number D and not sweat chloride test, right? That's a screening test, and we need to do sweat chloride do bari na. Okay. Rutvik's comment. Rutvik, could you just okay, graft is, yeah, that's what I want to know. If the graph is gonna be destroyed in 7 days, then I'll say graft failure. But otherwise, the presentation goes in favor of GVHD, na, graft versus host disease. Okay. No, that becomes a graft failure. No, if there's destruction of the graft tissue, then it's a separate thing. The way the question is given, that patient is having contracture, there are systemic symptoms which are given in a patient. Okay, so currently we are talking about the one where we are talking about after 4 days or 5 days, whatever was the value given, that the graft uptake did not happen, right? If the graft uptake is not happening after 5 days, I'll go by graft failure in a question. Otherwise, it is okay. The host cells are gonna be attacking. गॉट इट वो आप सिर्फ समझो ना कि डोनर के जो सेल्स है, ग्राफ्ट वर्सेस होस्ट डिजीज का मतलब क्या होता है कि जो डोनर के टी एट सेल्स होते हैं वो जाके रिसिपिएंट को अटैक कर रहे हैं ना. द लैंग्वेज ऑफ द क्वेश्चन वुड बी दिस ओनली. नाउ इफ आई गो बाय द लैंग्वेज दैट इज गिवन इन द क्वेश्चन, दैट इज कि जो पेशेंट है इम्यूनो कॉम्प्रोमाइज है, उसको कॉन्ट्रैक्चर है, सिस्टमिक सिम्टम्स आ रहे हैं आफ्टर अ वेरिएबल पीरियड ऑफ टाइम, द फर्स्ट आंसर दैट वी विल गिव इज जीवीएसटी एंड विल नॉट से ग्राफ्ट फेलियर इन दिस केस. डोनर टी एट सेल्स विल बी अटैकिंग द रिसिपिएंट ऑर्गन्स. नॉर्मली तो क्या होता है, रिसिपिएंट के इम्यून सिस्टम जो होता है वो अटैक करता है. सो इट इज द डोनर टी एट सेल्स विच आर अटैकिंग द रिसिपिएंट. सो एग्री दैट ही मे नॉट बी राइटिंग द वर्ड graft versus host disease, but the concept will be option number A in this particular case only. That's why the manifestations are developing in this patient. So anyway, like, this was a good input that I had. Okay, fine, I'll just take a snapshot of that. Fine, guys, I think we're sorted for this one. So thank you so much for joining into this discussion, and it was really a very fruitful one, and I'm really impressed with the kind of recall capacity that you guys have. I mean, to remember so much of data after 24 hours and much more of this is like really commendable. So at this moment, you can enjoy these few days, the remaining few days of, I can say, the freedom that you have, because after that you'll be busy with paperwork and you'll be busy with then applying in various hospitals, and then life becomes crazy, once you join your internship. So it was really fun interacting with you, and see you all on the other side, I can say. God bless you. My best wishes from the entire PrepLadder team. And with these words, I'll put an end to today's session. Thank you so much, guys. Bye bye. God bless you. नो बच्चे, नेगरी बॉडीज वुड बी पोस्टमार्टम ना बच्चे, एंटीमार्टम नहीं होगा ना. इट्स नॉट गोना बी एंटीमार्टम, इट्स पोस्टमार्टम दैट दे बी फाउंड. ठीक है गाइस, गॉड ब्लेस यू, टेक केयर, बाय बाय.